Today, we have Dr. Peter Palese, who's going to be joining us. I'll read you his bio. It is incredibly impressive. So Dr. Peter Palese, PhD, will discuss details about COVID-19, including the medical updates regarding vaccines and treatments. Peter Palese is an internationally renowned professor of microbiology and the chair of the Department of Microbiology at the Icahn School of Medicine.
Sorry, I couldn't hear what you said.
Apparently Siri was interested in you, Dr. Palese. At the Icahn School of Medicine at Mount Sinai. His research in the area of RNA-containing viruses with a special emphasis on influenza viruses. Specifically, he established the first genetic maps for influenza A, B, and C viruses, identified the function of several viral genes, and defined the mechanism of, you're going to have to make, I'm probably pronouncing this wrong, neuraminidase inhibitors, I probably butchered that, which are now FDA-approved antivirals. Since the beginning of 2020, there has been a shift in directions as work on COVID-19 has become central to the efforts by Dr. Palese. So we are going to turn it over to Dr. Palese. He is a co-host of this meeting and he will be sharing his slides and speaking. There will be plenty of time for questions and answers. And he is extremely open and flexible. So you can put questions in the chat. If that's something that you're not comfortable with, you can wave your arm and try to get attention, and I will be scrolling through. And again, we are honored to have Dr. Palese here with us today. If you take a moment and Google him, you will be incredibly impressed with what you found. So we were thrilled that he was willing to join us. So thank you so much, Dr. Palese. I'm turning it over to you. And you are on mute.
Okay, this is Peter Palese. As you heard, I'm working here at Mount Sinai. And the last year, exactly almost a year ago, we all really started working on COVID-19. And for us, it was not that difficult because most of us are virologists. We have been working for, in my case, since the last century on viruses, and particularly on viruses which have as their genetic information RNA, and COVID-19 virus is such an RNA virus. And as you heard, I am a specialist in influenza viruses, which is also a respiratory virus and is transmitted through the respiratory tract. And so for many of us, it was not that difficult to really change, but that's what we have done. So today I want to sort of go through some of the challenges which we face. And scientifically, let me tell you, it's really very interesting, but I understand the problems which I associate with it. So let's start out with COVID-19 stands for Coronavirus Disease 2019. And the virus which causes it is called SARS-CoV-2, Severe Acute Respiratory Syndrome Coronavirus 2. And it's similar to, remember, AIDS is a disease like COVID-19. It stands for Acquired Immune Deficiency Syndrome. But the virus is called HIV, Human Immunodeficiency Virus. So we have something similar here, that the disease, COVID-19, is different from the virus, or is named different from the virus which it is caused by. So it's SARS-CoV-2, and you will understand there is a SARS-CoV-1, and we will briefly talk about that. And I don't want to be a Cassandra, a bad predictions in the future, but there may be a coronavirus 3 or 4, and you can imagine it's not something which we would really like to do. So I have here a statistics from, and Nina, who is sitting next to me, was getting this. So this is really today, Monday, February 7th of 2021. And we have a total of 106 million people, give a couple of million plus minus in the world who have been infected. And unfortunately, we have 2.3 million deaths. And this is really something terrible, which is, these are big numbers, okay? And if you just look at what we have in the United States, we have something like 460,000 deaths. It's amazing. It's an absolutely a frightening number out of 26 million cases. And what you can see here is a map, and we have all of the countries of the states which have been really had tremendous problems with COVID-19. The little one on the right side here is actually Washington, D.C., and that looks sort of in the middle of cases per 100,000. But you can see this is a real problem. And you all know, and we all know, that we had the distinction in March and April of last year, 2020, to be the epicenter of the country. And we are not really right now. You can see there are some states which have a more intense blue color, but we still have a problem. Okay, so that's something which I wanted to mention, but also we have to put it a little bit into a perspective. So we have really 4.6 million deaths in this 1 year, but I will give you 3 examples where viruses have been really very, very bad. Yeah? And many of you know about the pox virus and what it causes, but you probably don't remember that in the 20th century, and specifically from 1900 on to 1920, exactly 100 years ago, the world had more than 300 million deaths caused by a virus, pox virus, and very few people know that. And this is really something very frightening. So if you think about the good old days, they were not that good. Yeah, we had in the 20th century, admittedly at the beginning, 1900 to 1920, we had more than 300 million deaths. And I don't want to belittle all of what happened in the 20th century, but the number 300 million really is quite, I don't want to say impressive, but we have had a big problem with smallpox in that very early time period. Then a little bit closer to what we remember. Does anyone know what that is? Oh, you're all on mute. I'm sorry. Then I have to ask. Then I have to ask Rachel. You know what that is?
Iron lung.
Yes, iron lungs. Yes, exactly. Yeah. Okay, so those were the poor kids who caught poliomyelitis, and there were these mechanical respirators, and they were basically putting pressure on the chest and then releasing it, pressure, release, press. And when you see this, the whole room here is full with those. And what people don't know is that very few of those terrible patients left them alive. So 80–90% of people who were treated in iron lungs died after 3 months, 6 months. So it's terrible. Okay, so just to remind you, this is obviously only in a history slide. We don't have those machines anymore, but just to remember, smallpox really bad, hundreds of millions of deaths in the last century alone, and poliomyelitis equally bad. And then you probably remember measles virus. So this is those are our 50 states here, and the colors mean how many measles cases were reported. And then you see in the middle, around 1966 something, a black line, which tells us when the vaccine was introduced. And then to the right of it, you have basically no more cases of poliomyelitis because of the introduction of the poliovirus vaccine, and that is Albert Sabin and Jonathan Salk, who, by the way, actually trained at Mount Sinai. Jonathan Salk was an intern at Mount Sinai. I think he told me once it was 1940, whatever, 3 or 44, but he had always a warm spot in his heart for Mount Sinai. So that's sort of just, unless you live in Santa Monica or in Beverly Hills, we don't have measles virus anymore. Yeah? So you know probably that there are some people who feel smarter than everyone in the medical field, and doesn't want to vaccinate anymore, which I think is very, very sad. And particularly also don't want to vaccinate against COVID-19. And we will talk about this a little bit in more detail. Okay, and then we have, as I said, about a year ago, exactly a year ago, we sort of started getting nervous. And this is from the Journal of American Medical Association, exactly January 23, 2020. And coronavirus infections more than just the common cold. Yeah, so at that point, it was still not clear what would happen. But this is really, it was quite interesting that even at that time already, we were somewhat nervous about what is going on. Now, what that is, a coronavirus, is a virus. And it is, as we talked about, it's SARS coronavirus number 2. But there was already a SARS coronavirus at the time, SARS virus, severe acute respiratory syndrome virus. And that was from 2002 to 2003. And it was a virus which belongs to the family of coronaviruses. And the name comes from, when you look at the left picture, that's an electron micrograph from an electron microscope. These particles are very, very small, okay? So if you look at this particle on my screen, it's about the size of my fist. And then a cell which gets infected by this fist is probably as big as the Annenberg building in which I'm sitting right now. And within 12, 15, 18 hours, one of these virus particles infects the upper left corner of the Annenberg building. And within that period of time, 100,000, 200,000 new virus particles emerge and basically destroy the cell. So that's what this SARS coronavirus is doing. And on the right side, there is a second coronavirus, which came about 10 years later and is still around, and it's called MERS virus, Middle East Respiratory Syndrome virus. And unfortunately, since we don't have too many camels on Fifth Avenue or Madison Avenue, this is not something we have to be concerned about. But what we have to be concerned about it is the SARS coronavirus 2. And that's what is shown here on the next slide. So we have here the SARS coronavirus 2, which is in all its beauty. And it looks very similar if you compare the colors are by computer, so don't get upset that they're not the same colors. You can make them any color you want. And you can see here that the picture of a SARS coronavirus 1 looks very similar to what we see when we have a SARS coronavirus 2. And it's sort of like the crown on the head of a king or a queen. And that's why they are called coronaviruses. And on the right side, you see lung cells, which are, and the yellow is in this case the virus. And you have all kinds of cells in the lung. And you can see that the lung is pretty full of this virus. So that is a virus which we have to deal with and which is sort of causing all of these problems. And it's called, as I said, the COVID 2019 virus. And the virus per se is called this SARS coronavirus 2 as compared to the SARS coronavirus 1 about 20 years ago. And then the one which is carried by camels. And one of the reasons, or one of the ways it's transmitted is that, and I'm just saying it, if you kiss a camel, that's a way of having the virus transmitted, okay? So it's not that likely that it happens in Manhattan. So that's one virus we probably don't have to worry in the future. Now, the virus is there are different alpha, beta, gamma, delta coronaviruses, which are slightly different, and it belongs to the beta coronavirus group. And many of the bat BAT coronaviruses belong to that same group. But as I said, there are alpha, beta, gamma, delta coronaviruses around, and they are different enough so that we can, if we get infected with a gamma coronavirus, I can guarantee you, and it transmits easily, I can guarantee you we can be very, very sick. And all the vaccines and all of the basically vaccines which we are having right now, and probably also some of the drugs, will not work again. And the virus, as I said, it was a small virus, and if I magnify the cell which is infected by these small viruses, like the Annenberg building, big buildings, they are infected by these RNA viruses, and they have this envelope which looks like a crown, and is the way how the virus is actually attaching to cells and infects them. And the receptor that's on the last line here is called ACE2. That's the name of the receptor. It's a cell protein, and the virus just takes advantage of it, okay? And there's no rhyme or reason which ones are used by different viruses, but they find a way to get in and cause us problems. And the most important problem is, most important protein is this spike protein, which is which is here in blue, and that's the protein which allows the virus to get in on one hand, but also we make, when we get infected, we make antibodies against this S protein, mostly, not against the other proteins. And then we have these antibodies are protective, and we are immune against the coronavirus too. And that's what is done by vaccines and also by natural infection, because someone who is naturally infected is unlikely, I think it's impossible, but let's say unlikely to get reinfected. And I also believe that people who had SARS coronavirus through COVID-19, particularly the younger ones, they should not really get vaccinated because they're using up some of the vaccines which could be used for people who really need it more. This is a little bit sort of my own opinion. You don't want to say this because you cannot be sure that a person really had coronavirus infection. So the hospitals and physicians are loath to use that as a criterion, because people could say they were infected. In reality, they had a little bit of the sniffles. So if one can really be sure that someone was vaccinated, was infected by SARS coronavirus 2, I don't think that person should really get and use up vaccines, which we need for teachers, sick people, people who have other problems. My own opinion, okay? So if you really are sure that you had it and have evidence, maybe you should not raise your hand to get the vaccine right away. Okay, so are there any questions, Rachel, so far? Anyone?
Yes, there are quite a few questions, actually.
Okay, go ahead.
A lot of them seem to be more clinical questions, so I don't know if we want to wait until the end. But the first one is it safe to get the vaccine while on chemotherapy?
Okay, that's a very loaded question, very difficult one, okay? Clearly, we would like to protect every patient from SARS coronavirus 2. And it depends on the status, on the immune status of the patient. If the patient is very immune suppressed, then the vaccine won't work as well, because if our body doesn't make good antibodies, then the vaccine is probably not as good. So I think it is really a question you have to speak to your oncologist about it. The timing is very important. If you are scheduled for immune therapy or cancer therapy, maybe you should get the vaccine first or afterwards. So all of that, these are very important questions, but you really have to talk to your specific doctor who knows exactly what kind of cancer you have and when you get immune suppressive drugs, etc. So a very important question. In principle, we would like to see everyone getting it. But I think in this situation, you really have to check with your oncologist, not your general practitioner, okay? You really have to get the best educated person in giving you some advice. Another one.
Yes, that's very helpful because a few of the questions had to do with that. And so a follow-up, what if you are on immunotherapy, specifically Keytruda? Would that answer still be the same?
For Keytruda, actually, it's no, it isn't, because that's actually enhancing the immune system. Yeah. So in that sense, it may actually give you a better response because it is a checkpoint inhibitor, which is actually enhancing your immune response. There you would have to, I mean, there might be a possibility that the immune response is too strong. Yeah. Again, you better have to check with your oncologist whether he or she would really recommend this. Yeah, but Keytruda basically would do the opposite. It would not immune suppress the patient, but rather activate the immune system, and that may actually not be so bad for the vaccine.
And another person did ask the question about immunosuppression due to chemotherapy. So it seems like you've answered that. Next is, what effect will the vaccine have on MBC patients on Ibrance and Faslodex?
Don't know enough about it. Okay.
Okay, so I think that the party line then for any questions like that would be to ask your specific doctor who's
yes.
treating you what the effects would be. You know,
Yeah.
again, if you're talking about any specialty medication you're on,
Yeah.
I think that's always important. Next is one of our patients, actually a volunteer, said, I'm presently recovering from coronavirus. I have the antibodies and need to be vaccinated. However, I have extreme reactions to vaccinations with live virus. I'm scared to take the shot.
Yeah. If I understood you right, she wants to be vaccinated again after having it?
Yes, that is the question. I mean, that's the plan.
Yeah, as I said before, I'm not so sure that, okay, it depends on okay, if the titer is very low, you know, and we know, and Mount Sinai is actually very good, you know, to have what we call a quantitative test for the antibody. If that is very low, let's say under 100, then I think it might be advised for a vaccination. But if the person has a good antibody titer, over 100, 200, 500, 1,000 even, which is common after COVID-19, I'm not sure that person really needs it, particularly if the person is worried about anaphylactic shock, et cetera, et cetera. So I would be, I think it is not clear to me, and I think my colleagues, most of my colleagues would agree with me, that if you had COVID-19, the vaccination is really, in most instances, innocuous, but I think not needed. And if we have a dearth of vaccine doses, maybe those people should not get it.
And thank you for clarifying that, because somebody did send a message to me individually to clarify. And I believe what you're saying is that the vaccine may not be necessary for patients who have organically gotten the disease and have antibodies organically
Don't call it
or
naturally. Yeah.
or naturally. And you know that may not it may not be necessary for those patients to get the vaccine since they already have the antibodies. Again, I would say for all of our patients to speak directly to their doctors, but you've been very clear about that.
Okay, so
the next question is about is it okay to take the vaccine on, and everyone's gonna have to bear with me here, on exemestane?
don't know.
Okay, so I would say let's turf that back to whoever the doctor is who prescribed that specific medication.
Yeah.
Um, the next question is, what blood work would show if you are immunocompromised?
Oh, that's a good point. Yeah. That's a very good point. Okay. I mean, in essence, you could only really definitively prove it if you vaccinate and measure the titer, yeah, whether it's really high enough. I mean, it's a very good question, and I think if someone is immune compromised or is under immune suppressive drugs, I think, as I said, the vaccine should be either given before or after a certain period of time, not during. But it's a very good question. How can you measure it? And the only good way would be to vaccinate and measure whether the person has an antibody titer or not. Yeah, and it's a very I like it actually. Yeah, it's a very intelligent question, but I can assure you we don't know. Yeah, it wouldn't be
I think
that.
that's it's an interesting point also, that as much as you are an expert in this, it's so new, all of this,
Yes,
that,
yes,
years from now, we'll have the answers to a lot of these
yes,
questions, interactions with specific medications, the best timing,
yeah.
but right now, and again, it sounds like nobody knows more about this than you do, but some of these questions you just
Yeah,
don't know. So,
exactly. Yes. Yeah.
the question is, um, if you are a survivor of cancer, so one of our participants is talking about people who had cancer in the past, is does the vaccine work? I guess I'm not sure. Amanda, you asked that. I don't know if you want to unmute yourself and chime in specifically with what you're asking, because I'm not exactly sure what you're asking there. You're saying, does the vaccine work for people who had cancer in the past, or does it depend on medication? Are you asking if different medications could interfere with how effective the vaccine is?
Yeah.
Yeah, I mean,
So,
if you had cancer in the past years ago, I think most medications wouldn't interfere with vaccine. Okay, only immune suppressive, any drug which futzes around, so to speak, with the immune system, either lowering it or increasing it. But other than that, I think you're fine. Okay. And one thing is, I don't, if someone has breast cancer, for example, and the lymph nodes have been taken from the right side, it might be good to get the vaccine on the other side, because if your lymph nodes are gone, you may have a worse reaction than on the other side. Yeah. So things like this you might want to consider. Did I make myself clear? That,
I think that's
yeah.
very clear.
So again, I mean, this is only for breast cancer patients, yeah. But if one, if one, most of the lymph nodes, if the lymph nodes of on both sides have been taken, then you can't do much about it. But obviously, I think that would be one consideration. Okay.
The next question is a very interesting one. Do you think that people will need to be vaccinated every year, kind of like the flu shot?
Okay. Okay. Again, Rachel, no one knows. The damn thing is only around for 1 year. And I can tell you, we are working on vaccines, etc. And in mice, and mice live 18 months about. Yeah, that's the lifespan of a mouse. And there, our vaccines and Moderna and the Pfizer vaccines are perfectly happy. They have a very good titers all the way and until the end of their lives, and which is only, I mean, we have some mice which have been vaccinated at 6 months of age, and now they're about to die, and the vaccines are perfectly, the titers are perfectly fine. But again, the question is, there's, Yogi Berra, it's always difficult to make predictions, especially about the future. And I think that's something here too, yeah, that we really don't know what the vaccine or the antibodies after the regular infection, how stable or how long lasting they are. But again, I would not worry any right now. The vaccines are superb, and we will talk about it. And we can, if it really turns out that the titers wane, then we will, just reading the New York Times, we will know about it, and then we just have to get a booster. So I don't think it's a big issue, the duration, because I think we have a good chance that they will last longer. Whether it's a lifetime, I don't know, but I think it's not going to be gone by June of 2021.
So the next question might be something that you discuss in the next part of your slides. So I might let you do some more slides and then we'll go back to questions. But can you discuss the differences between the vaccines? Specifically, is there the difference between Moderna, Pfizer, Johnson and Johnson? But again, you might discuss that. And also, I think if you could talk about the mechanism of what the vaccines are and what the vaccines do. So please keep the questions coming. We will get to all of them. But let's turn back to Dr. Palese and let him continue with his presentation.
Let me just, the bottom line is, you can switch off, all the vaccines which are FDA approved right now, the Moderna and the Pfizer, and also the Johnson & Johnson, which are coming, just take it. Yeah, they are all equally good, basically, and they're fantastic. I will expand a little bit on it. Bottom line, no difference, just do it. Just take it, okay? Now, let me go on then. I mean, we've all read about it and we know about it.
And I'm so sorry, Dr. Palese, your screen, oh, there, okay. Sorry, I think it was just on mine.
Is it okay?
Yep, now it's perfect, thank you.
So we all know what the clinical symptoms are: fever, cough, fatigue, anorexia, doesn't want to eat, shortness of breath, muscle pain, and then all these other non-specific symptoms. It's comparable to flu and some other common cold viruses. And then there are a little bit more severe manifestations, and that has to do with neurological symptoms, very high inflammation, what we call our acute respiratory distress syndrome. Also, unfortunately, people go into atrial fibrillation, older ones particularly after COVID-19 infections. There's also a big problem about coagulation, and people are giving drugs against coagulation. I'm not sure that everyone is happy with that treatment. Kidneys are unfortunately affected sometimes, and then even children, but this is very, very rare. Yeah, okay. I mean, it's on this slide here, but it's children basically are much better off really than the oldest amongst ourselves. Now, what we would like to know is obviously how is it being transmitted, and the way it's being transmitted is obviously one which is through a same as influenza, basically. I mean, I hope I have this slide here. So you have this guy here who is coughing, and these are famous photographs really of someone who has really a bad infection, and you can see this is a cloud of droplets, etc., and the viruses are in this cloud here, and that's how we get how the virus is transmitted. Now, most common it is among household members, also in healthcare settings when personal protective equipment is not used, and in closed settings. And then we all know how it is being transmitted, and the best is really 6 foot social distancing and wearing of masks, and trying to avoid going to bars if they are open, etc., etc. They say singing, speaking loudly, breathing heavily. I mean, all of that obviously can. I think you have to use common sense, okay? And this is our coughing fellow here, and you can see that this is really something which can be. You can see how the virus can be transmitted. And so again, on the right side, we have this particle. This is obviously a computer generated one, and these spikes on the surface is what our immune system sees on one hand, and what the virus uses to actually penetrate. And then, unfortunately, we know that the oldest amongst ourselves are very much affected, but among the young ones, also those who have certain underlying medical conditions who are really very much affected by the COVID-19. And it is not surprising because it is a new virus which infects us. And so we all, young and old, didn't have any protection, any protective antibodies in the past, because the other coronaviruses, which we have been infected, even worse, if someone was in Saudi Arabia or in an area where MERS was around, that antibody, even if someone had MERS or SARS coronavirus 1, he or she would not be protected against SARS coronavirus 2. So it is really something very different, and thereby was able to cause a pandemic. A pandemic means an epidemic which goes all the way around the world. And by having a new virus, which older people have now never seen, or young ones have never seen, the older ones are, like with almost everything, are more affected by something new. If people, like flu is not that much worse really in older people because they have seen it before and they have some partial protection. But against SARS coronavirus, the older ones are more likely to be affected by any kind of disease, are more affected. And then also people who are young and have certain underlying conditions. And you have seen what is here in number 1, that is cancer, that really gives you, because your immune system, if you have no lymph nodes anymore, and if you are on the immune suppressive drugs, etc. So this is something which you really have to be aware of. But it's not only cancer; it is kidney diseases, diabetes, coronary artery disease, and obesity. And again, obesity means that the virus actually, the mechanism is that viruses grow better in obese cells. And that's sort of unfortunate, but that's part of the reason that obesity is really, and a body muscle index of more than 30 is really unfortunately very sad complication, and is associated with an increased risk for severe illness. And then obviously smoking is never good. And these are these underlying conditions, and we would really urge people to get the vaccine after consultation with their doctors, because they are much more affected should they get infected. And again, we all know this. Please wear the mask, even if you are vaccinated. I think we should do this in order to protect our people, our other family members, other people who work in the same working environment. Please wear the mask and be sure that you maintain physical distance. It is really clear that if you have more than 6 feet, the virus is much less likely to be transmitted. And then please avoid any major, I don't want to say football events, but I think it would be good to avoid crowds and settings where there are many different people. And again, as you can imagine, outdoors is better than indoors. And also washing of hands is obviously something which cannot be done too much. So these are, again, you all heard about it, but I think it's something which is really important and has an effect, not 100% effect, as you all know, but it contributes to a reduction in the number of infections. And we will then talk about vaccines because I think they are more important than therapeutics at this point, even though we have recommended by the FDA right now remdesivir as an antiviral. It inhibits the polymerase of the virus specifically, and dexamethasone is a anti-inflammatory drug, which is sort of counteracting the hyperinflammation, which is part of many COVID-19 infections. And then we have other antivirals. People are talking about convalescent plasma. That's plasma from is blood taken from people who got infected. And if given at the right time, meaning very early, has an effect. If once you're hospitalized, the numbers are not very good. Monoclonal antibodies have been used, and you know that famous politicians, etc., have gotten this, and when given at the right time, fairly early, has a very good effect. And then also immunomodulators have been used. Nothing is perfect in this case. And anticoagulants, as I said, because coagulation problems are sometimes the result of COVID-19. And but again, the numbers are not that great. I think Mount Sinai has sort of backed off a little bit in terms of anticoagulants. But what is really important is vaccines, and that's sort of the last which I really want to stress, and then we can discuss in more detail. So we have these vaccine candidates. So there are at least 100 platforms from people. So this vaccine business and also the therapeutic, finding new therapeutics is like the Manhattan Project in the 40s. And I think I was told there were about 100,000 people involved, I think in terms of, in the Manhattan Project for the atomic bomb and nuclear research. I think here we have probably 1 million people involved in making vaccines, in making therapeutics. And this is a major, major effort. And I think it has been very, very successful because, you know, in the past, vaccines, the development of vaccines took 4 years, 10 years, even longer. So what we have seen here is we have the virus barely 12 months, and we have the two vaccines, which as I speak, have been FDA approved, and that is the Moderna and the BioNTech Pfizer vaccine. And they are of a vaccine type, the mRNA, and I will talk briefly about how that works. But then, let me sort of explain this. You know, biology is always DNA, our chromosomes, is transcribed to RNA, then the RNA to protein. And the proteins are really what we make antibodies against in the vaccine. Now, in the case of the mRNA vaccine, it's not that DNA is being used, but RNA, which is coding for this famous glycoprotein, the surface protein, the spike, the crown, so to speak, is made in our body from RNA, from messenger RNA. So this is really what is happening, is that one induces not the virus. So you can't get sick if you get the Moderna or the BioNTech Pfizer vaccine because there is no virus. What is there is just the RNA, which codes for the protein and is injected, and it makes in our body just the surface protein. It looks like the virus, but there's no infectious virus, nothing. So the mRNA is injected and produces in our own body the protein that we make antibodies against it. So that, and it's basically the same Moderna and Pfizer. They are fantastic vaccines. And as you will see, the only problem is they have to be kept at minus 80 degrees centigrade. So our refrigerators are 2 to 4 degrees centigrade. This is -80. This is very, very low temperature, and therefore very expensive. And the Moderna is a little bit better. I think it only needs -40. Then the second, and those are the other vaccine makers are now coming along. Merck, you can see, has an X because it dropped it last week. It wasn't good enough. And that is based on a viral vector. And what is being done there, the spike protein information is introduced into a virus, which is then given to people. And this is adenovirus in the case of the AstraZeneca and in case of Janssen, which is the Johnson & Johnson product. And the third way is having a protein subunit, just giving the protein, not giving the mRNA and not giving another virus into which the spike protein information is added, but just the protein is being given. And that is Novavax and also Sanofi and GSK. And they are not yet approved, but they will be coming, okay? And so this is really what's happening. Is Moderna better? Is Pfizer better? Is AstraZeneca better? It doesn't make a difference. Just get the one. And usually, I think we'll find out that probably one dose is already good enough. Certainly, you won't die anymore. And in order to stretch it, there are some thoughts now to actually give only one dose. But that's not yet really that clear. My recommendation is vaccinate whatever you can get, Moderna, Pfizer, AstraZeneca, Janssen, just get it. And understand we have chromosomes, DNA, which is transcribed into RNA, which is transcribed into protein. And in the case of the Moderna and Pfizer, it's just RNA is injected from which we make protein. And some other vaccines are that the protein alone is given, or that the information is put into a virus as a vector, and then we get then the vector is injected and we get antibodies against it. Now, the mRNA vaccines are the only ones right now which are I think the Johnson & Johnson is about to be FDA approved. The two which are approved is Moderna and the Pfizer in the US. And there are extraordinary results. And 95 plus minus protection of vaccinees. But even the 5% failures do make antibodies. The failure means that you have a little bit of the sniffle. Even the 5% failure do not die and are not hospitalized. So it's a fantastic vaccine. I have been working with vaccines all my scientific life. These vaccines are phenomenal. No mRNA vaccine has ever been made, and people have thought this is really bad. The result is extraordinary, okay? There are challenges in them in the sense that we have to have this cold chain of -80 centigrade or -20 or -40 for the Moderna. The duration is a problem. We talked about it, but I really don't think it's a problem, because if it does go down, we can get it not going down in the next 2 or 3 years, and then we can get booster injections. And also another thing which you might have heard of, that if we make an antibody, that there is suddenly an enhancement of the disease. And from all I know, it is not a problem with SARS coronavirus. So I think you can make an X there, but people have been concerned about it. And I think this is sort of, fortunately, should not be a problem. Any other questions so far?
So we have many, many questions that are waiting for you. I hope everyone is able to stay on. Do you want to take a break now and answer some questions, or do you want to continue with the presentation and hold them to the end?
Let's have some questions. People may want to leave, yeah.
Okay, so this is, I think, a similar question to what you were asked before, which is that should you have lab work that shows your CBC counts before getting the vaccine? I think you kind of answered that, but if you could just clarify.
I would go for the antibody titer, whether one has really a titer if you have been infected or if you have been. Um, if you want to know whether you are immune compromised, again, it's a question of your physician, really.
So I think, Mimi, I see that that was your question. So it sounds like you should speak, again, that question of whether you count as immune compromised or not, it
Yeah,
sounds like it's very specific to
yeah,
your
yeah,
situation, your lab work, your cycle of whatever treatment you're
yeah.
on. So
Yeah.
thank you. Should you have the vaccine in the arm you had chemo in?
If there's some um, reasonable time, namely months, I wouldn't worry about it. Okay. I
Okay.
mean, I don't think one should get vaccinated anyway if one is really in a cycle right now. But I don't think it has a long-lasting negative effect. I really don't.
Is the vaccine dangerous for women who want to have children?
Absolutely not. I mean, look, all the companies always say no, no pregnant women should. From what we know, it is really not dangerous. And again, please don't sue me, but I really, from all the information we have, there is no reason to believe that this mRNA vaccine has any real negative effect. I really don't think so. But again, a company will be they're unlikely to give you that okay, because they are too much afraid of getting into legal problems. But I really don't think so. And let, let me give you uh, when you get the vaccine, they don't ask whether you are pregnant or not. Okay, so in other words, a lot of pregnant people have gotten the vaccine, and nothing has happened. So I think that is some indirect evidence. So I look, don't sue me and don't quote me, but I really don't think it's a problem.
Several people asked if they have allergies to penicillin, amoxicillin, things like that. I'd also throw in, what if you've had negative reactions to vaccines in the past? Do you think it's still safe to take the vaccine?
Okay, it's again, I, I may, some people may disagree with me. I think it is such a serious disease, COVID-19, that a little bit of a red shoulder and pain, no gain, I think is justified, um, even for people who have had some allergies in the past. I think the danger, the threat of a COVID-19 infection, or even in those people who have allergies, is much, much higher. And I feel vaccinate, vaccinate, vaccinate.
Got it. This next is a really interesting question, which is, will the current available vaccines protect against the newer strains of the virus that have recently appeared in the US?
Yeah, okay, that's a very interesting, very good question. So we have done our also experiments in the lab here at Mount Sinai, and we get very good interaction of regular antibodies caused by vaccination with the new strains. And yes, there may be, it's a little bit less protective. However, the titers are so good that in the US, from what I have seen so far, I think they are perfect. Infection as well as vaccination with our mRNA vaccines are absolutely enough to protect against these new strains. What we read, and again, I think South Africa has today canceled AstraZeneca 1 million doses because they say it's not effective enough. But this is a very difficult situation. In South Africa, people may have worms, they may have bacterial infections, amoebal infections. They may be undernourished. So these are situations which are all not helpful for vaccination. So it is very difficult to, and also the number of uh, people who were vaccinated were only 2,000 or 3,000 people. So I think it's very low. I would not take the negative results in South Africa as the ultimate, the last saying on this. I think from what we know here, I think we are perfectly protected in the US against the UK strain as well as against the South African one. What will happen in a month from now, in a year from now, is a different story. Right now, I think, and some people say, oh, it's not working against the variant. I'm not taking it. Very wrong conclusion. Get the vaccine. The vaccine is, I would say, 95%, 99% also good against the, not even 100% against the variants, UK variant in South Africa.
And as long as we're talking about international things, someone asked the question about your opinion about the new Israeli drug XOCD24 related to COVID.
Don't know that. All I know is that Israel did a fantastic job of vaccinating its population. They are over 50% right now, a fantastic number. And they also have stretched it a little bit by giving mostly only one dose. I think it's a wonderful way of helping the population. I think the rest of the world should do what has been done, or is being done in Israel. I don't know this particular drug, to be honest. Or the name, I don't know. Yeah.
Okay. And then the
really,
last.
I would like to go for the Israeli vaccination campaign. Get vaccinated, get vaccinated, get vaccinated. I think it's much better than any therapeutic would be.
That's great. Then last question is, could you explain a little about how the vaccine protects against severe disease? And does it also seem to protect against long-term COVID?
Yeah, it protects against all of the above. Yeah. And clearly, the vaccine has been extraordinarily to basically prevent any infection in a large number of people. And only these few 5% where there are some symptoms and you can measure virus, they are in much better shape. They don't on the ventilator, they are not, no tracheotomy is done. They are much better off. And I don't think I have heard anything about these long-term effects really after vaccination. I think it's overdone and hyped up and used by some people not to get the vaccine. Again, the disease is much worse than the vaccine can ever be.
Right. I think let's continue. There are a couple of other questions, but let's continue with the rest of the presentation, and then we will, if there's anything else, then we'll just tackle those other questions then.
Okay, so if you don't have any other take-home message, vaccines are good for you, in particular in this case. And just be aware of the example in Israel where they really have done it. And I think their numbers are already going down tremendously in terms of new infection. So I think that's the way of going. We should get away from our 5% population. We should have 50% by now. And that's the way we can handle it. You know? Unfortunately, as you can see, this is from June of 2020, but it's not much better now, that just 50% of Americans plan to get a COVID-19 vaccine. And here's how to win over the rest. And I think it's very, very sad that there are so many people who are not taking the vaccine, having all kinds of excuses. Don't listen to them. Try to be, they should do it for themselves, but also for the rest of us. Yeah, I think that's sort of, I could go on, obviously, but let's find out if there are some other questions and we can discuss.
Sure. So some of this, we'll see. So someone's asking, since the governor said that as of February 15th, people with underlying conditions can get vaccinated, will Mount Sinai be offering the vaccine to its patients, and will they be notified for appointments? I don't know if that's your turf or not, but.
No, but I would hope so. My understanding is that they were very good, actually, our physicians, calling our patients and giving them the choice of doing it. Yeah. And I think particularly if the governor really is saying that, I think I can assure you Mount Sinai will do that, because we have been extraordinarily active in soliciting patients coming in and getting the vaccine, because we know how important it is.
And just for those of you who are on the call who may not know that there is, they did say publicly at the end of last week that as of February 15th, that people with a variety of underlying conditions, cancer being one of them, will qualify regardless of age. I do see that someone is commenting, unfortunately, that there are no appointments available. Getting the appointments is certainly a challenge. And I think that that is really hard. I don't think that's Dr. Palese's area of expertise. However, I would hope that Mount Sinai, would make it easier, to get access to those. And I can actually put in the chat for those of you who attended the benefits presentation as part of this series 2 weeks ago. She did end with several websites that are clearinghouses for people to get appointments. I know that doesn't help. It sounds like a lot of people are still really struggling to get the appointments. But, again, hopefully those clearinghouses will at least accommodate the influx of people that will be coming now that more people are going to be eligible. And that certainly is a justified frustration. I'm sure, that it's very frustrating for people who are eligible, who can't get appointments right away. There are a couple more questions. If you're on immunotherapy after the second dose, how long would the side effects last?
I'm sorry, say it again. To tell you, we were very surprised last week to find out that there is no correlation between the severity of the side effects and the antibodies. So in other words, we always thought, okay, if someone is really having a hard time, at least he gets a higher titer. That turns out not to be the case. And on the other hand, I think it's very unpredictable. If you have some immune suppression, whether you will really react worse than another person. So it almost looks like, to me, it's a little bit like a lottery. You win or you don't win. And there's no good reason. We thought that people who have a low immune level, they would not make a good antibody titer and therefore have much more symptoms. Not the case, okay? It's just, you just take it. But I can assure you, there is no one who got the vaccine has died of COVID-19 or was hospitalized for it, okay? It's possible that you have some more symptoms, but I think it is almost not predictable, okay?
The frustration of people who are trying to get appointments for elderly relatives and stuff and are worried about it. But, as we get information, we will certainly circulate it to try to make your journeys easier. But we do have a couple more medical questions. So, Dr. Palese, will vaccines cause inflammation, which could cause increase in CA-125 numbers or enlarged lymph nodes on the CT scan?
Yes, I've heard that. Yes, it can. And particularly, I mean, the issue is, that if you have some, okay, when you get the vaccine, and you get a reaction, then also the lymph nodes may become palpable. You may feel the lymph nodes and they may be a little bit inflamed. And if you have, for example, a breast biopsy, then they always look at the lymph nodes. And if the lymph nodes are inflamed, in the absence of a vaccination, you are worried. Okay, but the lymph nodes are enlarged because of the vaccination. And so there is a little bit of a problem. The doctor has to be very, you should certainly tell the doctor that you had the vaccine, because it sort of may mimic a worse cancer than it actually is. So that's a big issue. You know, I've heard this several times now.
That's
So
great.
just make sure that the doctor knows that you got the vaccine and that therefore the lymph nodes may have slightly different morphology.
Okay. Again, a couple of questions from people about, well, as a follow-up to that, around how long you would predict this inflammation would last if you know. Again, we understand they may not know.
Don't know enough about it, but it won't take that long. Okay, I really don't. It's not a. Okay, let me say I don't
Okay.
know, but the weeks should be taken care of that. It's not a month. Yeah.
Yes. And a few other people are asking about potential reactions. One person is asking, have you heard anything about a reaction to Taxol being related to a reaction to the vaccine also?
Nothing. No, none. I have not heard anything, and I doubt it. Okay.
And someone's commenting that there have been a lot of questions about potential allergic reactions. Are there any known, potential reactions or groups of people who have either allergies or had reactions that should be wary of getting the vaccine?
Rachel, I really don't think so. I mean, yes, we hear it, but it's anecdotal, and there is nothing to hang your hat on. Okay, I really honestly believe so.
Sure. No, and again, I think everybody knows that this is, that you are giving your most honest and best opinion here, and that obviously this is all so new that, again, if we had this conversation a year from now, 2 years from now, we might be able to go to a website and pull up all of these questions. And I think people are so eager for information, and I think that's what this is showing.
Yeah.
So a few people are posting about options for places to look online to get access to vaccine appointments. And one person is saying, be persistent, refresh the site every hour, and they do pop up. I have also heard about individual, almost like case manager type of people who will help advocate for, subgroups, and so if we hear about those, we can share that information too. Somebody is asking.
I really think your patients, if you're offline, I'm happy to talk to you about this. Yeah. I think
That's
your
great.
patients should have access, and I know that Mount Sinai is very open to that. Okay.
Okay, that's great. Let's cross our fingers, everybody. Thank you so much. And then again, this would be your opinion, but how long do you think immunity lasts after recovering for COVID? So I think the question there, call you out, is you're saying that you had COVID. You're wondering how long you might have the antibodies for.
Okay, again, this is something which we can't really predict, but I think if you had COVID-19 and have no side effects, move on, and just if there's really a big problem with people who had COVID and their immunity goes down, we will know about it. It's certainly not happening right now, and I would be very surprised if it really happens. And the vaccines, as a matter of fact, the titers are so good, and we have now 6 to 7 months data of antibody titers, and they are rock solid. So there is no evidence. Never say never, but at this point, I wouldn't be concerned. I think we should move on with our lives and not worry about that too much. I don't think it's an issue.
I think that's the end of our questions. I'm going to somebody just joining. I'm going to unmute anyone. So if there's any questions that you didn't put in the chat that you'd like to ask, and Dr. Palese, if you don't mind, if you could stop sharing your screen so we can see you larger, because you're small in the bottom there.
Sure.
Anyone have any questions that were not answered or that you feel like you'd like to ask at this point? I know we got a lot of information today.
no connection, no adverse negative connection I know of. I know people who have those allergies and they have been perfectly happy getting the vaccine without any side effects, etc. Cephalosporin, no problem whatsoever.
One more question here is, should I postpone my cataract surgery until I get the vaccine?
Yes, but only because you might be in a setting of the doctor where you have more interactions with people who are COVID positive. And I think I've heard this question before, yeah, because it's an important one. So I think it's only in terms of being afraid that you can catch it. So I mean, one thing would be to get vaccinated first and then do it, yeah, if you can get the vaccine. On the other hand, if you have to wait 3 months, it might not be such a good idea.
Got it. Thank you all so much for taking this time today. Dr. Palese, thank you again. We truly can't thank you enough for sharing your, expertise, your opinions, your knowledge of this disease, which I can't believe how much I learned, and I feel much more, just reading an article in the paper, I feel like I understand the situation so much more thanks to you. I'm sure all of our patients feel the same way. So thank you again.